All right, live recording. So we will scratch everything you just heard. All right. So today I have the pleasure to speak with you along with Kathy, my boss, and we're going to talk a little bit about patient experiences and how that impacts value-based purchasing. I know you know a lot about safety and the importance of that, but patient experience goes hand in hand with safety. One of the things that we'd like to talk with you about as far as patient experiences of care is HCAHPS. Are many of y'all familiar with HCAHPS? I see some head shaking. I see some people still not quite sure if they are awake yet, but that's okay. One of the things we talk about HCAHPS is it is a government-required program. It is part of value-based purchasing, and I'll talk about that in a little bit. But for Vidant Medical Center, we've set a goal towards each one of the dimensions in care. There were 8 up until this past quarter or until September. And starting this month in October, or I guess it's November, but starting in October of this fiscal year, 2014, they've added a transitions of care. So these are the dimensions of care that we have. So there's nurse communication, MD communication, which we'll focus on today, responsiveness, pain management, med communication, environment of care, discharge information, overall rating, and transitions of care, like I said, is the new one. And most of them have multiple questions within them. Overall rating is not the addition of all of them divided by, it is a singular question. So we used to base our goal primarily on the overall rating question. We have switched it because value-based purchasing takes a look at all of the dimensions of care, and they're pretty much equally weighted. So these are the goals that we have set forth, Vidant Medical Center along with Vidant Health. 85th is an improvement target. That's where we would like to be, but where we really want to be is in the 90th percentile. So compared to our peers, which is an apples-to-apples comparison, we are shooting to be a top decile performer. So that's a little bit of the information that we set as goals. Now, this is what the government says we have to do. We like money from the government. We love Medicare and Medicaid. So we're required to do several of these things. One is they have to survey patients that are at least 18 years and older. So children's surveys right now, although we do survey parents or guardians of children, those do not feed into that value-based purchasing dollar. Neither does behavioral health nor rehab. But what we do have is we have outpatient ED along with clinician groups and home health. Some of those are coming online very soon. They are actually testing the ED surveys. So we have one that's very similar to HCAHPS or HCAHPS-like surveys for all these other areas, but they follow the same rules. They're all payer types, so it doesn't matter if they're a Medicare patient, a Medicaid patient. It doesn't matter. They could be a med-cost patient. You may be surveyed yourself one day if you're ever a patient. So it doesn't matter what payer type it is. And you have to stay at least long enough to be considered an inpatient. So whether that's overnight or whatever the new rules are, to 48 hours. And we get this question a lot. Can we pre-survey the survey? We have people that want to do, and they oftentimes want to do the best they can, and they want to ask questions. And some of those questions are very, very similar to the nurse communication, the MD communication, so on and so forth. And we have to make sure that we really take a look at that in our office and make sure we're not violating the rules from CMS. So there's a lot of these scaled questions that may want to be asked, but we have to figure out another way sometimes to ask those. So they're very strict in how we ask and who we ask. We have a vendor known as HealthStreams Research that conducts the survey for us. And surveys are also based on the discharge units. So you have areas like an ICU, MICU, for instance, may not technically discharge a patient, but they put them to an IU area, whether that's 2 South, 2 East, MIU. The survey comes directly out of where they're discharged from. The thing is, you got to remember, the patient may have come from the ED. They may have gone to an ICU and then to a step-down area like a 2 South or 2 East. They're going to remember their stay. So that's why it's important that as we move along through the continuum of care that we do a good job of making sure the patient has the best experience possible. But it is, the scores show up in whoever discharged the patient. So if it's 2 South, and I'll show you what those scores look like. They're called up to 5 times because that's what's required. They try them at night, they try them in the evenings, they try them during the days, they try them on a weekend, they skip a day. There is Spanish speaking right now. That's the largest portion of the population in the U.S. other than English speaking. So they do have a bilingual service that they also call patients and ask them the questions in Spanish. And they have to be asked in set order. So why is this important? And the reason understanding what top box is important is just simply that this is the only way we get paid or reimbursed. If we don't perform at the very, very best level and we don't perform better than others, we will lose out on value-based purchasing dollars. And that's millions of dollars, by the way. So top box for us are based on depending on what the questions are. They're frequency-based, so how often did somebody do something? How often did the doctors do a good job of communicating with you? Always, usually, sometimes, and never. If we get an always, that's great. If we get anything else, it doesn't count. That overall rating question I talked about, it is a scale from 0 to 10. 9 and 10 is the best. And then we do have a couple of very dissatisfied through very satisfied. These are the only ones that count. Now, I know you said y'all love math, right? Love statistics. But this is simple math. So if 90% of VMC's patients give us a top box rating, doesn't matter which question is, and the average is 90%, somebody in here tell me what percentile rank they think that would put us in. 50th. And y'all are right. So we use this slide a lot to tell people it's not that we are doing a horrible job, it's just we have to do better than others. Because if you're at the 50th percentile, you don't lose any money from CMS or Medicare, but you don't get any money either. You're just average. And so that's why we bring this up a lot, is to show people that you may be 90% of your patients satisfied. I hear the insurance commercials all the time. Our customers say we're 95% satisfied with our services. But what do the other insurance companies say too? 95% of my customers are satisfied too. Well, so on average, you're just average. So who's the ones that are 99%? So, but anyways, this just goes to show that even though we may be at 90% of our patients giving us the best rating possible, we still may only be average. So we talked a little bit about the questions, and so we'll focus on the physician piece, the physician communications. So you can see here, it's how often do the doctors treat you with courtesy and respect? How often do the doctors listen carefully to patients? And how often do doctors explain things in a way that can be understood? Now, these are the three questions pertaining to physician communication. But you play such a bigger role also. I mean, it's what kind of medications are ordered, what do the discharge orders look like, all those pieces. And so kind of understanding what we look at, there's no better gift that you have than communicating with the patients. And so we really are looking for that always experience for every patient that you touch, serve, and support. So how do we do? This is Vidant Medical Center for all of the MD Dimension score. You can see that 86.4% in 2012, 85.1% in 2013. We had a little bit of a slip. We've gone down a little bit. But in that small function down, that small slide down, you can see we go 11 percentile points difference. Because there's two factors hitting here. First factor that hits us is that we have not performed as well as we did the year before. Then the other piece that happens is we talk about we're compared to apples. It's a fair game. Doesn't matter if we're a large, small hospital. The government takes a look at how well we do and how well others do, and the competition is getting harder and the bar is being raised. So if the average in the database starts moving up, which it has consistently since 2008, then as the bar moves up and we slide down, we kind of get a double whammy. Our percentile rank severely drops. And 1 percentage point can gain you 10 percentile points sometimes. That's how small of an impact that you have to make on patient experience that can get you big grounds, because that bell curve is so tight. So little movements in the positive direction get you big gains. Of course, the opposite's true. And we don't like the opposite, so we'll stay the positive. So these are the scores. Yes, sir.
Has the government looked to see if those kind of changes are statistically significant changes?
They are, and one of the reasons they do is because they do it across all hospitals who want Medicare dollars. And what they'll find is as some of those changes get to be tighter and tighter, you will eventually start seeing questions fall off. They do that for core measures. We measure X amount of core measures. As everybody started getting right close to that, whatever that percentage is, that 50 percentile rank, whatever you want to call it, and everybody's at that top performing 90, 95%, then they'll take that question away or they'll take that core measure away. But that hasn't happened yet because there's still big grounds to make. But you are right. They do look at that, and one of the reasons they added that transitions in care question is because they took away that patient advocacy question, that likelihood to recommend, because that's what they saw. They saw that kind of, well, everybody's grouping very similar in that, and they took that away. So, now this is medicine's division. You can see very similar. We've had slides across most areas, but what I want to show you, because this is very similar information, and we'll make sure that you get the slides as well. But you can see we've had 0.2% change in doctors listening carefully to patients, which that's 5 percentile point changes. But again, that goes back to the average moving up and us moving down a little bit. But here's 2 Souths. So the reason I put 2 Souths in here is I understand a lot of the work that you do is on 2 South as well. But I want to kind of bring your attention to this one here. You can see we actually did have a gain in that particular question. We actually had a 0.4% increase. Point increase. So that, I mean, that to me is very, very good. The problem is that because everybody's gotten better over the last year, including us, in most things, it still gave us a drop in our performance as far as percentile rank goes. Are there any questions on this? I want to move on a little bit to value-based purchasing. Okay. That is a busy slide. Wouldn't y'all agree? You know, we talk about value-based purchasing. There are 3 things right now. There used to be 2. It used to be your core measures or your clinical measures and your HCAHPS experience or your patient experience. And we really like to call it patient experience, not necessarily HCAHPS. But what this goes to show is at one point, 1% of Medicare funding was being held back. And it used to be pay for participation. As long as you participated in the HCAHPS survey or the patient experience survey, and you took place and you took part in your clinical measure scores, and you provided the government with that information, you would get your 1% back. But now it's moved to performance or value. And so how much value we add on these 2 measures, they held back 1%, which was the equivalent of about $1.5 to $1.75 million for Vidant Medical Center. Now that has changed. They have increased it to 1.25% holdback. That will continually rise until they get to about 2%. And then they'll probably change the game. We know that. They have added this past year, past fiscal year 2013, optimal care. And that's your mortality rates. And so they do AMI, heart failure, and pneumonia. So this is the area that Kathy and I and a lot of our office concentrate in, is the patient experience. And this is what they call a value-based purchasing scorecard. Now, our vendor provides this to us. It is older data, although we can see hospital experiences more real time. Of course, you see it every day. And our vendor allows us to see scores more often. What this picture is what the government is showing our patients and families out there in the community. It's about 9 months old because the government goes in and scrubs all the information and makes it clean and makes it fair, or whatever you want to call it. But this type of information is what our patients can see. These are people who, they go on the computer, they go to hospitalcompare.gov. They can see how well our mortality rates are. They can see how well our safety rates are. They can see how well we're doing in experiences in care. So if you take all 3 of these pieces, HCAHPS, clinical measures, and the outcomes themselves, they'll give us a score. And each one of these have weights. This is worth 25%, this is worth 30%, and this is 45% here. What I'm getting at is, for the foreseeable future, this one stays at 30%. This one will move to 30%. This one will go up a little bit, and they're going to add one. I can't remember exactly which one it is, but they're going to add a 4th one pretty soon. So it'll be the 2 big ones are still the clinical and the HCAHPS, or the patient experience scores. And so they heavily, heavily tell us if we do well, we're going to get not only our money back, but other people's money. I can tell you right now, this is the most recent scorecard we have. If you can see it, and I know it's hard to tell, but we actually get 0.65% of other people's money. I don't know about you, but I like other people's money. How about y'all? But what's more telling is it says that we do a good job. We can do a better job, but we do a good job in patient experiences. We do a great job in our clinical outcomes. And we got some work to do in our mortalities as well. But you can see that right now they hold back 1.25%. roughly $2 million, a little over $2 million for Vidant Medical Center. We get back 1.9%, which is a great thing for us. I mean, it goes back to investing in education. It goes back in investing in machines and things that we need to be successful. But the thing we have to remember is you can control this, but this is all about the patient's perceptions. You know, we may not be able to do everything we can to save somebody's life, but we do everything we can to save their lives, but sometimes people die. But we have an impact here. But this one right here is all about the patient's perception. And it's hard to measure a patient's perception unless you can communicate with them, unless you can build a relationship, and Kathy's going to talk a little bit about that.
Before we move on to the next section, do you have any questions about the data? Yes, sir.
Is the data fine enough for you to give feedback to individual providers in the hospital? If you really want to improve performance, what you do is you tag a bonus to how well people are scored, and you give them some benefit for putting in that extra effort.
Right. We do have the ability, if the chief of service requests kind of a scorecard by a physician, it is done by the either admitting or attending physician or the discharging physician. We can drill it down to that level.
And the thing is to make sure, particularly for the hospitalist services, which shit gets pretty heavy, is to make sure they don't have so many patients so they don't have time to clearly communicate.
Well, and the piece for that is to see how their scores may stack up against others who are not hospitalists. So, anything else? Okay.
Okay, we're gonna talk for a few minutes now about some specific strategies that you might want to employ to have an impact on patient experiences and care. And you can leave it right there for just a minute if you want to. Kevin's talked a lot about the data. He's talked about, you know, this transition over the past few years to value-based purchasing. We know there are going to be a lot of other changes that we're already starting to see with the Affordable Care Act. And we want you to get the message today, though, that the impact that you have on patient experience certainly is about all these changes and moves that are going on. But bottom line, it's the right thing to do. It's the right thing to do. It's probably why you made the decision that you made to be here, to be a physician, and to be joining with us at Vidant Health in our mission of serving the community and patients that we have that come to us. It's the right thing to do because there are a lot of changes that are going on right now with patient engagement. And I was a patient about 11 years ago. I was diagnosed with breast cancer. And I had a wonderful surgeon by the name of Rosa Cuenca. She's not here anymore, but maybe some of you knew her. When I got that diagnosis, I had been a nurse at that point for over 20 years. I had connections, I had resources, I knew how to search out the literature to look at best practices. But you know what? I was still in the mode of being patient. You know, the doctor was going to tell me what I needed to fight my breast cancer. The doctor was going to make the decisions. The doctor was going to decide on whether I was going to have a mastectomy or a lumpectomy. The doctor was going to determine whether or not I had chemo and radiation. I was still looking at it that way. And Rosa Cuenca came into the room and she looked at me and she said, "We are going to battle and you are leading the charge." That's a totally different perspective than how I had operated as a nurse before, than how I had operated as an operational leader at this hospital before, even than how I had operated in my dealings with physicians before. We're going to battle, and you are leading the charge. And I learned a lot about being an engaged, activated patient at that point. My father is currently dying of end-stage heart failure. And I'm learning a lot about how to be an engaged, activated family member. And last week, at his doctor's appointment, Dr. Al-Husani looked at me and he said, I cannot tell you how wonderful it is to have this connection and relationship with your family. He said, this is how I want to practice. Patient family-centered care, patient experience, is about one word. It's a partnership. It's a partnership between physicians, nurses, other members of the healthcare team, patients, and families. You know, it's a culture, it's well-researched. In some ways, it's a bit of a buzzword out there in healthcare. But the one word I want you to associate with it today is partnership. And it's the right thing to do. Your patients are going to be different than my 75-year-old parents. They want to be informed. They want to be engaged. You know, they don't want you to just tell them what to do. And actually, at our hospital, you might be familiar with the PAM score, the Patient Activation Measure, which is a way that we actually administer a tool and figure out on a 4-point scale the readiness and willingness, the skills, the competency of patients to engage in their own care. And with your newly diagnosed diabetic, that's a 1 on that scale. Are you going to give them the whole shebang? No, because they're not going to be able to understand it. They're not going to be able to apply it. And 99% of their care is going to be at home. It's going to fail. If they're a 1, you're going to do what it takes to keep them out of the hospital again. And you're going to rely on those community resources to get the diet teaching and the details of teaching. So engaged, activated patients, that's where we're going. We've got a whole team at the system level that's helping us to understand what that means. We have a new office that is actually looking at patient education in a totally different way, redoing all the patient education materials that we have out there, looking at a vendor to support that. You're going to see a lot of changes over the next even 12 months with patient engagement. And so how can you impact experiences in care? Understand that you're a part of a culture that's moving very quickly, and that traditional practices and approaches are not necessarily going to be what it takes to get to the quality, safety, and experience outcomes that we want to achieve. Impacting experiences in care is also important, not only because of this impact on value-based purchasing and because it's the right thing to do. It's important to your practice, to your developing practice. You go out to eat a meal in a restaurant, and you have a really nice meal. How many people do you think you're going to tell about that? Give me an idea. You have a really nice meal down at Starlight one evening. How many people are you going to tell? Not many, right? Yeah, you might tell 3 or 4 people. That's exactly right. That's actually what the research shows. You'll tell 3 people about a really positive experience that you had. How many people are you going to share it with when you have that really bad experience down at Starlight? Everybody you meet that day. 25. On an average, 25 people. And so in terms of building your practice, it's important that you pay attention to patient experience. And the core of patient experience, and if you'll flip that, Kevin, has to do with communication. And so we just want to share a couple of things today that are evolving expectations for physician practice in our health system. And leaders like Dr. Rummans and Dr. Herman are really understanding and valuing the impact of some of the behaviors and best practices that we've got on this checklist. Now, sometimes when you think about a checklist, you think about it in terms of, I'm going to walk in the room and I've got to follow this. That's not what this is. This is more something like a toolkit. This is something that you can use as a guideline until you get these behaviors and practices hardwired into your practice. It's said that patient experience begins and ends with good communication. And if you can't communicate, it really doesn't matter what you know. So the communication is the key. We want these things not necessarily to be add-ons to the clinical care that you provide, but we want them to be core clinical skills that you provide. And the first one I want to mention is right up there with the X, knock, introduce, and describe. And I remember it KID, K-I-D. And I can guarantee you that if you can do this and do it consistently as a team, you're going to change some things. You knock on the door and you wait for the patient or family to answer. When our patients are here, their rooms become like their bedrooms. It's their private area. And knocking on the door is very important. You walk into the room and you simply introduce yourself. We did a little exercise not long ago, and we looked at a woman that comes in simply to deliver a baby. You know, they're here a little bit more a day. We do this all the time. You know how many people in our hospital that patient is going to, on average, interact with? It's going to come into her room during a 24-hour period. Any idea? 15? Keep going up. Keep going up. It's about 60. You're right. You're in the range. About 60 people. 60 people come into your office today. Are you going to know why they're in your office? Are you going to remember who they are? Plus, add to that, you've had pain medication, you've just delivered a baby, you're overwhelmed. You need to introduce yourself. Not only the first time you go into the room, but every time you go into the room, because our patients are bombarded on a given day with a lot of people. When you introduce yourself, it's very simple. My name is Kathy Dutton, and I'm one of the administrators for the Office of Patient and Family Experience. And you describe your role. I'm here today to talk to you about your experience in care. Is that okay with you? So in less than 7 seconds, I've knocked, I've introduced myself, I've described my role. Does the patient and family then have clarity about what's going on? Yes or no? They do. They have clarity about why you are in their room. So the KID mnemonic is very simple, it's very short, but I'll tell you, it can be very sweet in terms of enhancing that physician communication component. Sit down to speak with the patient. There have been some really good studies out there that have shown that physicians that round at the door frame versus physicians that round at the bedside, eye level to patients. The physicians that are eye level sitting, talking to patients, actually spend less time with those patients. But the patients rate the quality of that experience much higher. So you save time, and the patient gets a better experience just by going in, doing the KID mnemonic, less than 7 seconds. And if there's a chair in the room, and I know that's a challenge sometimes, but if there's a chair, having a seat, pulling up a seat, getting eye level with that patient, making the eye contact, and talking with the patient. The other thing that's really important that we didn't put an X by, but it's clear contact with the family. And in our health system, we define family very differently than a lot of other health systems. If I asked every one of you in the room today, tell me who your family is. You might say your husband, your wife, your boyfriend, your mama. Some of you might say your dog, your pastor, your best friend. We let the patient define family. And we also support family presence, as you know. And so acknowledging not only the patient when you go into the room, but acknowledging the family that's in the room as well sends a key, clear message to the patient that you care about them and their experience. Under Educate Engage, we want to pull out just one thing. That's discuss findings, options for treatment, and expected clinical course. We've got a really good tool in every room in this hospital. It's called the whiteboard. You know what I'm talking about. The whiteboard can be written on by any of us. And we encourage you, as you go into the room and as you speak with patients and families and you're setting goals for the day, and you say, in order to get home, we need for you to walk around this unit 3 times a day. We need for you to use this little breathing machine. We need for you to eat a regular diet. Whatever the goal is, get it up on the board. I can tell you it makes a huge difference for patients to understand the role that they play in getting better. That fosters engagement. There are a lot of patients that I round on when I go into the room and I'll say, tell me why you're here at the hospital. And they have no clue. Being honest with you. Tell me today what you can do to get better. What you can do to get home. They've not been told. It's very simple. That whiteboard is a tool that's in your room. Please use it. Jot notes up there. I can wholeheartedly tell you that patients have nothing else to look at but what's on that board. And if you put something up there, they're going to live by it. They're going to do their very best to meet it. And the last thing I want to mention is around listen and learn, giving patients time to respond. You've been pretty good with the numbers over here. If you go in to do an initial assessment on a patient, and you go in and you say, Miss Dutton, you know, tell me about what's going on with you. Why are you here today? On average, how long do you think the physician is going to give the patient to share that history? How long? How many seconds or minutes?
Yeah, I would say maybe even a little bit less than that. Most physicians probably closer to 3 to 4.
There are some studies that have shown 18. There are some recently that have shown 7. 7 seconds. So I've got to give you my history, you know, and let you know why I thought it was important enough to be here today in 7 seconds. And so understanding that patients need a little bit longer than that you will actually save time if you give the patient a little bit more time than that to actually respond and to get the issues on the table. When you leave the room, it kind of goes back to what I shared, that the patient experience is all about communication. It begins and ends with communication. And when you leave the room, it's just like you're going to do the kid mnemonic when you go in, knock, introduce, describe. When you leave the room, you want to make certain the patient has an understanding, as well as the family, of why you were in the room. And so that simple question that you can ask. Some people have trouble with the question, is there anything else I can do for you? Some people don't like that question. But there has to be a closing question. There has to be an opportunity for the patient to say, I didn't get everything I needed to get out of this. What else can I answer for you today? What else can I explain to you today? What else can I do for you today? Some type of closing comment that's going to ensure that the communication loop has been closed. So all of this sounds pretty simple, right? And in the practice situations that we're in sometimes, I get it. Acuity's high, volume's high. So I'm not here, and Kevin's not here, to teach you strategies that are going to make your day longer. It's already long enough. But I am here to say that sometimes the way that you do things, the way you've been taught to do things, the way you've, worked into your practice, are maybe not as efficient or effective as they can be to get the outcomes you want. And if you can tweak that practice a bit and actually save time, then why wouldn't you do that? And so the KID mnemonic is proven to be a time saver for you, and it's a great way for the patient to understand who you are and why you have business in their room. Sitting down, again, proven to be a time saver for you, plus the patient's perception of that interaction is going to improve. Making sure that people understand what they or their family can do to get better. Use that whiteboard in the room. It's yours. It doesn't just belong to nursing. That is your board as well. And then making sure that you give patients a bit more time to respond. Getting that clarification, getting those issues on the table up front saves you time in terms of having to do that later. What questions do you have of us in terms of where we're going with patient experiences and care, the impact that you can have? These things are what we want you to integrate into your practice. And when you do that, you'll start to see tick-ups in the scores that Kevin shared with you. We are not all about a number at our hospital. We use the numbers to set goals. We have to have something to drive towards. But this is really where it meets the road in terms of those daily interactions that you're having. And these are some very concrete ways that you can make things better for patients and families. Any questions that you have today? And I'll end today. You got one over here somewhere? Okay. Yes, sir.
Now you talked a lot about the whiteboard.
Uh-huh.
I'd argue that the whiteboard actually back to a space where we can write something
Yes.
and tell you what you're going to do today. You got to tell us one line.
That's very good feedback. And in some of our areas, if you practice down or you round down in rehab, you know the boards in rehab? They're very big. We're actually going to be doing, from my understanding, some trials in rehab with some digital boards in rooms, which I think is going to be cool. But I appreciate that feedback. Thank you. Yes, ma'am. We have worked very hard on that. In fact, I know on some of your units, like on 2 East, I think what the manager has done is taped a ruler to the end of the marker so that you don't put it in your pocket and walk out the room. But we've actually do frequent orders of markers. We ask the managers and charge nurses when they're doing their roundings to make sure they're there. If you're consistently seeing you don't have a marker on a unit, give me an email, Kathy Dutton, and I'll get it straight. I'll get it straight. Yeah, markers, a little thing like that, the devil's in the details, that can be a barrier. Yes, ma'am. Yes.
Now, is that something that's going on the inpatient side as well, where patients every day are asking what goals are for that day?
Absolutely. The emergency department, and that's a great case study of how a tweak or change in practice that really didn't take a lot of time really worked to clarify the goal for that visit. I used to be over the emergency department. People come into the emergency department, as you well know, with chronic conditions that they've had for 10 years. And on that visit to the ED, they're expecting that visit to be the miracle visit, right? You're going to heal me, you're going to solve my problem, you're going to diagnose me on this visit. So that's right. So we were seeing that in their scores. Patients were saying that I didn't get what I wanted out of that visit to the emergency department. So here's what we did. Every patient is ask, what do you expect from this visit today? And if I'm that chronic back pain patient and I say, I want you to figure out why I've had this pain for 10 years and I want you to make it go away, then as a healthcare provider, I'll look back at you and say, that we're not going to accomplish that today. I'm sorry. But what we can do today is to relieve this acute pain that you're having, and we can get you referred. That's the goal that goes up on the board. So there's a clear understanding and communication with what we are going to accomplish. What happened, and Kevin, I can't remember the exact percentages,
Well,
but
so we set this task now technically 2 fiscal years ago. They did it really, really well in one quarter, and they saw their scores go up significantly. And again, I know we say it's not about the numbers, but it's the only way for us to measure sometimes. They did a great job, celebrated, good job, and then they didn't really do it anymore for a while, and their scores went right back down. So they didn't hardwire.
up and down.
So they started out this fiscal year about the 40th percentile. And I say about, it might have been 37th or 43rd, I can't quite remember. But they started the fiscal year at the 40th percentile for the first quarter. They have, because they have started hardwiring this, and it's being done more and more with a mutual agreed upon goal between the physicians, the patients, and the nursing staff, they actually finished this previous fourth quarter at the 91st percentile. So from the 40th to the 91st. And every quarter they were getting better. So we continue to see this trend, then we know it's hardwired. And so, I mean, that's one of the reasons we look at the numbers, is it kind of gives us a detail of where we need to focus. And it was because of that goal. So that's a great thing for those who work with the ED. Congratulations on that. It's big.
And if we can move that consistently into the inpatient setting, it'll make a huge difference. It'll make a huge difference. I like to give this very simple example. I was rounding one evening on a patient actually over in the Heart Center. She had 3 blocks on her whiteboard. They all had check marks in them. I said, tell me about your whiteboard. You know, what's with that? And she said, they let me know that if I walked 3 times today, then I'll go home tomorrow. She said, and I wanted a checkbox every time I did my walking today. She said, and I'm going home tomorrow. So your plan of care does not have to be, you know, like we traditionally think of a plan of care written out. It can be 3 boxes on the board. It's mutual understanding, the partnership between you and the patient. But they've got to know they want to be engaged. We've got to open that door a bit, because we're dealing with a culture that has not necessarily always been used to that level of activation or engagement. So it's a mutual partnership right now. But yeah, that's one thing. You're very familiar with the quality bundles. You know what you need to do to prevent a CAUTI or a CLABSI or VAP. What we're saying is that these are the bundles for physician communication. And in the long run, we think they'll save you some time, too. A double win. What other questions do you have for today? Okay. Well, thank you for letting us be here today. We really appreciate Dr. Asker inviting us.